Dear colleagues and friends, our thoughts are with you during these difficult times in China with the coronavirus epidemic. There is not much we can do to support you, but we came up with an idea and we hope you will find it valuable. Through the WeChat app, Dental Campus is offering educational content from its platform freely available to all dentists in China. We hope you will find the content interesting and valuable for your practice. In the meantime, we hope the epidemic will be over soon, and we wish you strength and endurance. I am Christoph Hammerle from the Dental Campus Association. Thank you.
Dear colleagues, welcome to Dental Campus, to lecture on implant surgery. After the initial exam and risk analysis, the treatment planning and the preoperative preparation, which were extensively discussed in the previous lectures, we are now ready for the surgical intervention of implant placement, which of course begins with local anesthesia and ends with a wound closure. So in this lecture, we will focus on the first part of this surgical treatment step. So how to ideally gain the access to the bone site, which is planned for the implant placement. So the objectives of this lecture are on how to ideally place the local anesthesia, which is the adequate incision technique, and how to elevate the mucosal flap. So first of all, let's review how, or better, where to ideally place the local anesthesia prior to the implant placement. So the localization of the local anesthesia will primarily depend on the site which is planned for implant placement, which means the part of the alveolar ridge which will receive the implant. And in second place, of course, on the extension of the mucosal flap. So when placing an implant in the maxillary molar region, there's going to be need to perform, of course, a greater palatine nerve block, to perform an anesthesia of the maxillary tuberosity, and in addition to that, to perform anesthesia local infiltration in the area of the buccal flap. When placing an implant in the anterior maxillary region, you will start with a nasopalatine nerve block, and in addition to that, perform a sufficient local anesthetic infiltration in the entire region of the buccal flap. When placing an implant in the region of the canine or of the premolars in the maxilla, we will again start with a nasopalatine nerve block, perform a local infiltration in the buccal area to get again the anesthesia of the superior alveolar nerves, and finally perform a greater palatine nerve block. So now, let's take a look at how to ideally place a local anesthesia in the mandible. When placing an implant in the mandibular molar region, you will generally start with a truncular anesthesia of the inferior alveolar nerve. And concomitant to that, we will get an anesthesia of the lingual nerve. Thereafter, we place anesthesia of the buccal nerve, and there is very often need to perform a local infiltration of the area of the buccal flap. When placing the implant in the region of the mandibular premolars, again we start with a truncular anesthesia of the inferior alveolar nerve. There is generally, in addition to that, need for a local infiltration in the region of the lingual mucosal flap, and we perform an anesthesia of the mental nerve in the region of the mental foramen. And finally, when placing the implant in the mandibular frontal region of the canines or the incisors, we will place a local anesthesia in the region of the lingual foramen, and a sufficient infiltration in the entire region of the buccal flap, and sometimes there is a need to perform a truncular anesthesia of the inferior alveolar nerve. With regard to the choice of the instruments for the incision, so the choice of the surgical blades, the blades number 15, 11 and 12D are among the most commonly used surgical blades. However, the use of microblades is highly recommended to place very precise incisions, especially for the sulcular incision and generally in the aesthetically sensitive areas. When placing incisions, it's very important a precise single incision technique and the use of sharp instruments, which means when needed, intraoperatively change the blade in order to always cut the tissue with a very sharp instrument. Regarding the flap elevation, there is a wide range of instruments for the elevation of the mucosal flap, and generally we use large elevators in the edentulous areas and try to use as small elevators as possible in the region around the teeth, so to elevate the gingiva. But however, it's important to underline that today really the use of micro-instruments, of microsurgical instruments is highly recommended in order to traumatize the soft tissue as less as possible. So let's start with a straightforward case. As you can see in this image, we have a single gap in the posterior region, a missing first mandibular molar. We have a sufficient amount of bone, or we expect that, and we have a sufficient band of keratinized mucosa. So in this case, we do not expect a need of GBR procedures concomitant with implant placement, and in these cases, generally we choose transmucosal healing modality. So we start with a sulcular incision at the both adjacent teeth, and this incision is placed to reach the contralateral buccal line angle of the adjacent teeth, and thereafter we place the ridge incision in the middle of the band of keratinized mucosa, which in this case corresponds with the middle of the ridge. We elevate the full thickness flap with a periostal elevator to gain the access to the implant site, and of course to check whether any bone defects are present, and the defects are most often present at the buccal aspect. Very important, don't forget to taste the lingual undercut, so to control, to check the extension of the sublingual fossa by using a small, slightly curved periostal elevator, because for sure you want to avoid these type of errors. You see in this case the tip of the implant reaching the sublingual fossa, and of course you all know in this case there is quite a high risk of postoperative bleeding. So this is a straightforward implant placement. There is no need for a periostal release incision, and in this case we choose a transmucosal healing modality. So this is a second case where we see missing mandibular molars, and in this case the placement of the single implant in the position 4-6 is planned. Clinical examination, we see sufficient bucco-oral dimension of the alveolar ridge, or at least we expect that. There is a sufficient amount of keratinized mucosa. So again, in this case we start with a sulcular incision. We place the sulcular incision to reach the contralateral buccal line angle of the second premolar. Thereafter we place the ridge incision in the middle of the keratinized mucosa and place a distal vertical release incision. So this is a very elegant technique which allows an excellent mobilization of the flap and an ideal access to the bony site. So again, we check for the presence of the bone defects, and again, very important, check the presence of the lingual undercuts by using elevators, of course. The implant is placed. Again, it was a straightforward procedure. Now, another advantage of the distal release incision is the possibility to obtain a very nice adaptation of the buccal mucosal flap by mobilizing the buccal flap in the mesial direction. And in order to do that, we have to start the suture from the mesial aspect in the distal direction. And if the buccal flap is sufficiently mobilized, it's possible, as in this case, to gain a beautiful band of keratinized mucosa around the implant. So let's continue with another case. Here again the posterior mandible. In this case of a young female patient with missing tooth 3-5 and a pronounced atrophy of the alveolar ridge, in addition a reduced amount of keratinized mucosa, it was planned from the beginning to perform a correction of the deficient buccal contour by doing a GBR procedure concomitant with the implant placement. So we performed the mesial-distal ridge incision exactly in the middle of the keratinized mucosa. Since the transmucosal healing modality is planned, of course we want ideally a sufficient amount of the keratinized mucosa both at the buccal and at the lingual aspect of the implant. We continue with a circular incision by using a microblade, and again the same technique, this incision is placed to reach the contralateral line angles of both the adjacent teeth. Now whenever performing a bone augmentation procedure, it's necessary to place a vertical release incision. In this case, we're in the posterior region. We're going to place the vertical release incision on the medial aspect to gain a better access to the bony site. So we place the incision. We start from the contralateral line angle of the adjacent tooth, and we start perpendicular to the gingival margin for a few millimeters, and thereafter we continue apically into the oral mucosa. Now we start by elevating the gingiva, so the elevated mucoperiosteal flap from mesially by using a small elevator. Try to be gentle with soft tissue and try to work manually to proceed in an efficient way. So in this region, of course, in the premolar region of the mandible, it's important to identify the mental nerve and the position of the foramen in order to avoid injuries during the implant placement or during the flap management. Again, we examine the lingual region by inserting a small slightly curved elevator, and here you can already appreciate on the right aspect the situation after the placement of the implant and after a GBR procedure. So we realize there is an additional volume to be covered with soft tissue, and therefore whenever doing bone augmentation procedures we always have to perform a periostal release incision. This can be done prior to implant placement or after GBR procedure. In this case, you're in the posterior region. We start from mesially, we start from the vertical release incision, which makes it more simple to correctly identify the correct layer to place the incision. And at the end, of course, very important, prior to the suturing, control whether the buccal flap is sufficiently released to allow a tension-free closure of the soft tissue. In the following case, there are missing posterior teeth in the maxilla. We see that there is a horizontal atrophy of the ridge and also reduced amount of the keratinized mucosa. It was visible in the radiographic image that there were only few millimeters of bone left in the vertical dimension in the region 2-6, and therefore in this case a primary sinus floor elevation in the region 2-6 in combination with a minor horizontal bone augmentation in the region 2-4 was placed in order then in second step to be able to place two implants in the positions 2-4 and 2-6. Again, we start with a sulcus incision by using microblades in order not to traumatize the gingiva around the teeth. Thereafter, a mesial-distal ridge incision, very important, always place a ridge incision in the keratinized mucosa. And finally, a vertical release incision which has to be sufficiently long in the apical direction in order to gain an adequate access for the lateral window in order to perform the sinus floor elevation. You see the situation after the flap elevation, so the flap, the full thickness flap has to be elevated and mobilized quite an extensive way. You see an atrophic ridge after several years after tooth loss. We performed quite a small window in the region of 2-6 and thereafter a minor bone augmentation by using the xenograft granular material in combination with the resorbable collagen membrane stabilized with resorbable polylactide pins was performed. And therefore, in this case, in order to control the entire region, to control the bone augmentation procedure, it's important, again, to extend the mucoperiosteal flap sufficiently. Here we see the situation after approximately 6 to 7 months. We see that there is a slight scar of the original incision, and now we are ready for the re-entry and the placement of the implants, and we use the same incision as used 6 months prior to this intervention, and in this case we plan a transmucosal healing modality, so we plan to mobilize approximately 2 millimeters of keratinized mucosa to the buccal aspect. The both implants were placed without need to perform additional bone regeneration procedure, and a minor free gingival graft was placed in the inter-implant region, position 2-5. And here we see the initial situation and the situation approximately 1 year after the start of the treatment. So we are really able to widen the keratinized mucosa by placing or by using the correct incision technique, and so we were able to move approximately 2 millimeters of keratinized mucosa to the buccal aspect in the horizontal dimension, and the same you can appreciate in the vertical dimension. It was possible by doing this procedure to correct the vertical position of the keratinized mucosa. So now we move to the anterior region, and you can appreciate the situation of a single gap of a missing tooth 2-1, which was extracted, and this is a situation after a socket preservation technique in combination with a punch graft, so we have quite a nice mucosal situation. So generally, when placing implants in the aesthetically sensitive regions, we always do perform a GBR procedure concomitant with the placement of the implant. In terms of the incision technique, we start again with a sulcar incision. Again, we reach the contralateral line angles of the adjacent teeth by using the microblades. Thereafter, the ridge incision is placed slightly in the palatal position, so not in the middle of the alveolar ridge. Important, use sharp instruments, use a precise technique, and try to cut the tissue only once. And thereafter, one release incision is placed on the distal aspect, and of course, if there is a potential risk, especially in cases with thin biotype and in cases which are aesthetically very sensitive, it's even possible to extend the incision in the distal region to reach the canine or to reach the premolars, and thereafter place the vertical release incision in a posterior position. Here you can see the mucoperiosteal flap is raised, and again it's very important to mobilize the flap sufficiently in order to gain a sufficient overview of the bony situation, to get a control and possibility to perform a proper GBR procedure. And the second reason is to be able to mobilize sufficiently the buccal flap, which is going to be important to gain a tension-free closure of the wound. Again, you see the implant is placed in a prosthetically correct position. There is an important buccal dehiscence, however, it was possible to reach the primary stability in the apical region, and we perform concomitant GBR procedure with resorbable membrane, xenograft, granular material. It's important to overbuild this mechanically not stable materials. So we appreciated the incision technique for GBR by using resorbable membranes. The same technique is used for GBR, which is performed concomitant to the implant placement by using non-resorbable material. Again, the vertical release incision is placed distally, and of course there is a possibility to extend this incision even more in the distal region. When using non-resorbable materials for GBR, generally after 6 months we perform the re-entry procedure to remove the non-resorbable material and the pins, and it's necessary to perform the same ridge incision, so slightly in a parallel position, sulcular incision, and to remove this non-resorbable material. There's another case. You see a primary horizontal bone augmentation. We are still in the anterior single gap missing tooth 1-1, so the horizontal augmentation was performed by using an autogenous block harvested from the retromolar region, fixation with 2 stabilization screws, again the same incision. We see the vertical release incision on the distal position on tooth 1-2. Again, re-entry after approximately 4 to 5 months when using autogenous bone block, and in this case, in order to be able to remove the stabilization pins, it's generally necessary again to perform a vertical release incision. So this is another case. We stay in the anterior region, in the anterior maxilla. However, now we have to deal with a multiple gap. So in this situation, we have missing 4 incisor in the maxilla, and due to the fact that the prognosis of the both canines due to the endodontical status was compromised, it was decided to go for a fixed implant supported construction, and after performing a 3-dimensional cone-beam CT examination, so you can see on the cross sections that we had to deal with a major horizontal atrophy in this anterior region. So of course in this case it was planned to perform a primary bone augmentation by using autogenous bone blocks harvested from the retromolar region. Again, we proceed with the same incision technique. We start with a sulcular incision by using micro blades. We place the ridge incision from mesially to distally, so from canine to canine, replacing a sharp and clean cut, slightly in a parallel position, and thereafter a vertical release incision is placed on the distal aspect of the canine or on the distal aspect of the first premolar. After raising the flap, cleaning the region, performing the bone augmentation procedure, it is still possible to decide whether an extension of the flap, so an extension of the incision, is necessary or not in order to reach a tension-free primary wound closure. So which means that we place our incisions in order to have the possibility to extend them either by extending the circular incision in the region of the teeth 1-4, 1-5, or we extend them by placing a second vertical release incision, in this case on the right aspect. And again, of course, after the GBR procedure, a periostal release incision is going to be very important to reach a tension-free primary closure. When placing implants in edentulous jaws, as in this example, this edentulous maxilla, where a fixed implant supported reconstruction was planned on implants placed in the canine, premolar or molar region, and a slight horizontal augmentation to correct the deficient buccal contour of the ridge in the anterior region. We place the ridge incision in order to have a sufficient amount of keratinized mucosa in the buccal aspect, and we place 2 release incisions distal to the planned molar implantation site. So it's very important never to place vertical release incisions in the regions where the implant may be placed or where a bone augmentation procedure may be necessary. So you see, in this case, 8 implants were placed in the posterior region, so the second premolar and molar 6 mm implants were placed in combination with a sinus floor elevation with a Summers technique, and the flap was sufficiently mobilized on the vestibular aspect, and due to the large dimension of the flap, the mobilization of the buccal flap is simplified, and there is generally no need for major vertical release incisions. In cases with a sufficient amount of bone, and when the patients are medically compromised, one may choose a minimal invasive procedure to reduce the postoperative discomfort and the risk of certain complications. However, in these cases, it's important to have at disposition a sufficient amount of keratinized mucosa. Now, by using the principle of the static guided procedure, in this case, we use a 3D printed guide and we use a guided tissue punch to remove the keratinized mucosa and to gain the access to the bone. So it's important to remove a sufficient amount of soft tissue in order to avoid the risk of transporting parts of soft tissue into the implant bed, which may compromise the osseointegration process of the dental implant. And here you appreciate the same case at different steps, so the guided drilling procedure, the guided implant placement, and the insertion of the implants. Again, these cases are rather rare, so the cases really where the bone and the amount of the keratinized mucosa in an edentulous jaw is sufficient. So we get to the conclusions of this lesson. We saw that the localization of the local anesthesia depends on the site of implantation and on the extension of the mucosal flap. With regards to the incision technique, it's highly recommended to use microblades, especially around teeth. One has to be precise, perform single, not multiple cuts through the tissue, and when necessary, change the blades intraoperatively in order to be able to always cut the tissue with a very sharp instrument. When planning a bone augmentation procedure, always place a vertical release incision. When placing the implant in the posterior region, the vertical release incision is going to be on the medial aspect to get an adequate access to the bony side. When placing the implant and GBR procedure in an anterior side, the vertical release incision is going to be placed on the distal aspect. And finally, in aesthetically sensitive anterior regions and in cases with thin tissue biotypes, it's recommended to extend the incision as distally as possible. And finally, regarding the flap elevation technique, we saw that it's necessary to elevate the gingiva around the teeth by using microsurgical elevators in order to traumatize the tissue as minimally as possible. We have to mobilize the macroperiosteal flap sufficiently to gain an adequate access to the bony side in order to be able to perform a clean augmentation procedure and to get a proper overview, and on a second aspect to allow a proper mobilization of the flap. We saw that when performing bone augmentations simultaneously with implantation, always do perform a periosteal release incision in order to get a tension-free closure of the wound, which is the key for the successful wound healing. I thank you very much for your kind attention.